Good morning. I would like to thank you very much for having us here, and I'm very proud and honored to be in the center where the founder of primary care of Croatia started primary care. It's very symbolic, I think, that we're here now at this moment. Thank you very much for that. I will go into the accreditation system in the Netherlands, and I will show to you how this accreditation system in the Netherlands works, but also I will try to make the development that we are trying to make into a certification of a system, and I hope that I can all make it clear, because if I can make it clear, I understand it myself very well. So then we will at least know what we are aiming at in the next years. I'm a GP in the Netherlands. The Netherlands is, England is over there on the left side, so then you have the Netherlands. Amsterdam is far away from Nijmegen in the east, where I live. I live in a small, and work in a small village near to this town. These are a few figures of the Netherlands, and this is my practice. We have over 3,000 patients, and with 2 colleagues I work together, practice assistants and 1 practice nurse, just to give you an idea. Talking about, and what I forgot to say is there is a small sticker on our window in the practice that says this practice has accreditation. So that's quite important, but you couldn't see it on the photo. The system of accreditation in the Netherlands, we have a program since 2005 for continual improvement of the practice. It was developed by the general practice, the GPs themselves. We had some collaboration with health insurance, but they were more in a secondary phase. It was really introduced and made from within the group itself. And the Dutch College of General Practitioners, together with IQ Healthcare, have set up the first phases of this accreditation system. And it has a benefit and it also has a challenge. I will come to that. There's 2 sides on this story. What it meant to have insight in one practice organization, also medical performance, but also experience of patients. And then we would give feedback and benchmark, which would work as an incentive for improvement, because this whole system was made on making improvements. That doesn't mean that we would lay the standards very high. We would lay the minimum standards at an acceptable level, but at least the improvement would be the motor or the whole engine of everything. It would help in accountability and transparency, because you would get the possibility to get your figures out. And good quality of care, of course, was the major aim of this whole exercise. The characteristics are a 3-year cycle in which you go through a development of things, and I will explain to you what it will be. There will be measurements, feedback on different subjects, like I told you from what this exercise was about, so the practice organization, patient experiences, and the medical performance. It was flexible. Flexible means that the practice could choose where to improve on. And of course, it would be a bit strange if they would improve on diabetes if their diabetes was done very, very well, and asthma COPD was done very poor. They had to explain, of course, if they wanted to choose diabetes as their focus for improvement. But working with the improvement plans is the core business. That was the most important part. That doesn't mean that we put the standards, just like I told, but even a practice that is not performing very well and that is very active in improving is entitled to have the accreditation stamp. The instrument itself, you start with the assessment. The assessment is made for you and will not be done for you, so you have to do it yourself. It's quite a lot of work in a practice, and it depends also in the system that you have in recording. If you have a very simple system, that means a lot of work. If you have a system that can take out the data from your computer automatically, your work will be, of course, much less. There's a big difference in that. The practice management is part of questionnaires that you have to fill out, practice management about what your practice has, for example, in kinds of material, hygienic procedures, safety procedures, but also working hours, and that counts for the doctors, that counts also for the practice assistants. So they all get questionnaires that they have to fill out, and that will give this report on the practice management. Medical performance is done on the major diseases, the chronic diseases that we know, diabetes, asthma, COPD, cardiovascular disease, but also on antibiotic use and some medication use and preventive medicine, such as influenza vaccination and cervical smear examinations. So they will all be put in a report that you will get back. And patients' experience were done using the EuroPEP questionnaire, which was developed by several countries in Europe, and is, well, we will hear later about it by the next speaker. So in the first year, you were working on the data collection, then analysis of the data took place. There was feedback and benchmarking, so you could not only get your figures back, but also from the rest of the Netherlands that were having their figures, and you would learn how do I stand compared to the rest, and not only how do I stand compared to the mean, but also we made it in 4 quartiles. Compared to the whole group, am I in the lowest quartile, am I in the middle 2 quartiles, or am I just above in the highest, from 75% to 100% of the results. Then there was the drawing up of the improvement plans, and you drew up the improvement plans helped by a consultant that would be available, because these plans had to be smart plans, they had to be measurable, they had to be specific, and so at least that you could also evaluate them. And after that, an audit would take place. So you would have a visitor in your practice. The visitor in the practice would look through the data collection you would have done. That means that would also look at the way that you enter your data into your computer. For example, if you use the ICPC coding for diagnosis in your computer or not, and to what extent. But also, they would look at your vials for acute care that you have in your box, in your bag. For example, whether you have the adrenaline, whether you have certain drugs that you need. There's a list about 16 essential drugs that we agreed upon in the Netherlands. They would check whether you would have them, but also whether they were not expired. And you would be amazed, maybe look in your own bag one day, you would be amazed how vulnerable this small item is. It's unbelievable. Then with this audit, you would have the result of this audit, and if the audit was positive with regards to good improvement plans and setting the minimal requirements that you would have, then you would have the accreditation after 1 year, and it would last for 3 years, just as in the UK. So this drawing up plans, just in detail more, these plans had to be drawn from the 3 dimensions, one on practice organization, one on patient evaluation, and one on medical aspects. So in our case, we worked on, for example, the waiting time problem in the waiting room. Our telephone system would need improvements. But also on diabetes, we would start a program in our practice. Then it should have relation to the feedback report, as I already said. And well, it's of course it gives a flexibility to the practice to choose which gets the priority. And I don't mind so much about that, as long as you use the feedback report as the basis. But I think the problem should be practice owned, and that's a very important aspect. It should not be the idea we have to do this from the accreditation system. No, we see our feedback report and this is our idea about it, and this is what we should do in our situation. This is what I already went about. The audit is the review of the plans. Are the plans heavy enough, not too simple? Are they realistic? And this assessment I already talked to you about. I talked a bit faster than my slides go, I see. Then for the second and the third year, then first, of course, the auditor would come back. You would have an evaluation of your improvement plans. The evaluation would be sent to the auditor and together with new plans for the second year. So the auditor would look at are the goals of the first year, are they achieved? Are the new plans sufficient? And in relation also to your feedback report. And again, the minimal requirements like the vials in your bag will be checked each year. And even after 1 year you will be amazed. And of course, I know as a GP that if tomorrow my accreditation, my auditor comes, then my practices system is sent to review my bag, of course, today again. And it's unbelievable, but there's always something to improve. So that's in the second and the third year, and this gives a continuous cycle. You just continue improving. If you look at the number of general practitioners that are involved in this aspect, we have about 40% of the GPs in the Netherlands that do that, or almost 4,000 now. And if you look at the patient population involved in a country with 16 million inhabitants, we have quite a lot, also about 40% of the population that is belonging to a practice that has an accreditation. So I think we reached quite a nice goal already if you look at the volume. And what helps is that the practices that have a trainee in their system, they were more or less required to join, not forced to join. Well, maybe it's something between required and forced, you could imagine. There's always something. The problems that we encountered was that we got, as a matter of fact, it was a system from within. And that's why I said in the beginning there's two sides on this medal if you organize it yourself. We had insufficient support from other stakeholders. They said, okay, it's your system, it's not our system. And we had maybe too much influence from the GPs themselves. Half of the auditors was also a GP. That is an advantage because you have someone who is, of course, one of you who is coming to your practice and who can understand very quickly your reference. But on the other hand, it helps sometimes also to see someone who is from a bit outside and can more have a helicopter view on your practice. And then the transparency was insufficient. Also what goals were reached, it was very much on a voluntary base. So that's why we tried to think about a better system and improving the system.